Good afternoon, everyone. Welcome to the University of Utah and Bateman Horne Center's Long COVID and Post-Viral Syndrome Echo. I'm Talia Rasconi. I'm the Education Director at the Bateman Horne Center, and I run these sessions with Echo Manager Sarah Day. I'm really looking forward to today's presentation on when exercise doesn't help with occupational therapist Amy Mooney and physical therapist Clayton Powers. Amy, I'm going to turn the time over to you to give us a brief introduction on yourself, and then Clayton will take it from there.
Hi, everybody, and thank you so much for attending this presentation. My name is Amy Mooney, and I'm an occupational therapist. I have focused my treatment approach for people that have post-exertional malaise, who have ME, and who are seeking help regaining the life they used to live and restoring their occupations of daily living. I appreciate your attention, and I hand it over to Clayton.
Thanks. So I'm Clayton Powers. I work at the University of Utah as a physical therapist, and I primarily specialize in helping patients with long COVID, ME/CFS, POTS, and other neuroimmune conditions. So go ahead and get started.
Looks good.
And what we'll be covering is post-viral syndromes when exercise doesn't help. Here are some of our learning objectives that you can refer back to after the presentation, but we hope to have an engaging discussion afterwards. And I'll be presenting two cases of patients who were diagnosed with long COVID and are on different ends of the spectrum as far as their ability to tolerate activity. So the second most common symptom of long COVID has been shown to be post-exertional malaise in a lot of the studies. And as you can see here, some of the other symptoms that are common with long COVID, but post-exertional malaise is a frequent symptom that patients complain of. And it's the hallmark symptom of ME/CFS or myalgic encephalomyelitis. And here's some other studies showing high proportions of post-exertional malaise and orthostatic intolerance in people living with long COVID. And then this study showing that the orthostatic intolerance in long COVID has some similarities with the orthostatic intolerance in patients with ME/CFS. So post-exertional malaise, it's a worsening of symptoms and function after physical, cognitive, emotional, sensory, social, orthostatic, all forms of exertion. And so symptoms are disproportionate to the level of exertion. So they're very unpredictable. If you've worked with patients who have had these symptoms, it's really hard to know how much exertion is going to lead to the symptoms. And you don't really know. It can be unpredictable in terms of the intensity and the character of those symptoms because it's usually delayed in onset by hours to days. And then patients will have a prolonged recovery time lasting hours, days, weeks, or longer. And this is usually triggered by a viral or bacterial infection, but it can be also triggered by other forms of trauma to the body or stressors to the body. Post-exertional malaise, as I mentioned, is often delayed and can be triggered by a variety of different forms of exertion, like upright positions, sensory activities, concentrating or having a conversation, socializing, emotional, both excitement or eustress, like positive emotions and stress or distress, negative emotions of stress can trigger post-exertional malaise, which is just kind of an increase in symptoms. These are all patients that I've seen in terms of their response to exertion. So patients will try to do activity and then they'll report that I went skiing a day and then it landed me a week in bed sick with flu-like symptoms, or I went to a party and socialized and that led for 2 days in bed sick. One of my recent patients said her PA recommended that since she has long COVID, she should start exercising 5 days a week for about 20 minutes on a stationary bike. And she tried 15 minutes for 3 times a week. And that led to her being bedridden for 2 months. And so this is where a lot of harm can be caused if we're not screening for post-exertional malaise in these patients. What happens is that they engage in physical exertion like exercise, and then hours to days later, they experience a worsening of those symptoms, as I mentioned. So in one study, they looked at doing max cardiopulmonary exercise tests with patients who have ME/CFS. And what they found was these tests are about 6 to 8 minutes long. So it's a ramping protocol of exercise, either on this is usually on a stationary bike. There are treadmill based ones, but what they found is that sedentary deconditioned individuals, 85% recover in 24 hours. On the other hand, 0% of ME/CFS patients recover in 24 hours, and only one in this study recovered within 48 hours. So there's this abnormal recovery response. And as you can see, even deconditioned individuals recover in 24 hours. So that can be a big sign if somebody's taking longer than 24 hours to recover, that they may, that's a sign of post-exertional malaise. Other research has been done with invasive cardiopulmonary testing. And what they found is that the exercise limitation in patients with post-COVID syndrome is due to vascular dysregulation and also impaired oxygen extraction. They find that these patients attain anaerobic threshold at an early stage or a low heart rate. And I'll go into that a little bit more thorough we'll go into that. And then they find a reduction in VO2, or the ability to consume oxygen, and it's not due to a central limit like issues with the lungs or heart. It's due to peripheral at the level of where oxygen is extracted and used as fuel for the anaerobics or the aerobic system. And it really comes down to, there's two main energy systems of the body. There's three, but I'll just mention the anaerobic and aerobic. The anaerobic system doesn't utilize oxygen to make energy, whereas the aerobic does. And so if you're having issues with extracting or using oxygen, then that's going to impair the ability of the aerobic energy system to make energy. So it's a dysfunction in how the body creates energy. And as you can see, before COVID, an individual might be able to get up to 170 on their heart rate before they ever reach that point that they go into the anaerobic system. So most of their activities, their ADLs and other things, are in the aerobic system. And then after COVID or a viral infection or other stressor to the body, that can happen at a much lower heart rate. I've seen patients where they start entering that threshold at 85 or 90 beats a minute. In this case, I used 100 as that to show that these patients with post-exertional malaise use the anaerobic system at lower heart rates. And so they spend more time in that anaerobic system, which can lead to that post-exertional malaise or that run-down feeling in the body. So patients with post-exertional malaise use the anaerobic system at lower heart rates, and that's a strong predictor of endurance performance. Activity above that level is not sustainable. It's only designed for about 2.5 minutes or less. It's the system used for like weightlifting, sprinting, high intensity activities, or those that don't require oxygen. So once you go above that, blood lactate levels rise, and going above that frequently in a day or two for too long will result in PEM. Lactate can build in the body faster than it can be removed. And there have been some studies showing even resting lactate levels have been shown to be high in patients with long COVID and ME/CFS. And during a PEM episode, when somebody's in a crash, they use the anaerobic system at even lower heart rates. So maybe on a good day, they're able to go up to 100. On a bad day, maybe it's only 95 or 92 before they enter that lactic acid threshold. And so if they're already activities of daily living are already putting them at high levels of strain and exertion, and you can't just keep adding more strain to an already strained system and expect that it's going to work. So a lot of these patients can't tolerate exercise because they're already going into that lactic acid threshold or that anaerobic threshold with their ADLs. In another study looking at ME/CFS and cerebral perfusion, they found that what's surprising is that in a subset of patients, even with normal heart rate and blood pressure responses during a 30-minute head-up tilt table test, they found that there's a 24% decrease in blood flow in the cerebral perfusion. And so even in those patients who may have symptoms, but you can't really see a change in that heart rate or blood pressure in upright positions, they may have diminished cerebral perfusion. And in a different study, they found that cerebral perfusion remains reduced even when patients lay down in a supine position or they go to a reclined position. It can take a while for patients to get that blood flow back to their head. I've had many patients with POTS describe that it takes about 30 minutes or so of laying down before they feel like they start to get some energy. So there's this delayed response or delayed recovery even when laying down. And this is a recent study just came out this month showing that we need to be screening for post-exertional malaise on a regular basis because failure to address post-exertional malaise roughly doubled the risk of health deterioration following rehabilitation, and not addressing PEM substantially increased the probability of a decline in health and functioning following the intervention. So we need to be screening for PEM on a regular basis with patients in general, especially those who are going to be undergoing rehab and may be advised to exercise. So the key points before I get into the cases, rehab providers need to be screening for PEM on a regular basis and offer an alternative treatment approach. Since graded exercise protocols like the Levine or CHOP protocols can be contraindicated in patients with post-exertional malaise, and it can be detrimental for those patients. So the primary goal of therapy would be to reduce, prevent, and manage PEM episodes. And a secondary goal would be to help improve that patient's quality of life and function. Many patients or PTs still use graded exercise to try to recondition patients who have PEM, and it's not very effective and has been shown to lead to increases in worsening of function and the symptoms. So some of the most effective treatments are activity pacing, education, and energy conservation. And this is just for your reference, but a therapist needs to take into consideration to limit PEM and then set expectations with the patient that this is going to be a long-term management. It's going to be validate the patient's experience and set those expectations early that it's going to take some time and learning. So the first case I want to present is a female in her in her 30s. She was diagnosed with COVID in 2021 and then made the rounds through the healthcare system, as a lot of these patients do, and was treated by multiple providers and diagnosed with multiple different things. And as you can see from her tests, most of them were pretty normal. A lot of her notes say normal for this and that. Autonomic neurology testing showed that she has symptoms of orthostatic intolerance. She didn't necessarily meet criteria for POTS that day. And then these are some of the medications and things she was trying. And prior to starting therapy, she was given the Johns Hopkins COVID rehab handout, which encourages increasing cardio and activity and doesn't really mention post-exertional malaise or pacing. And so it wouldn't necessarily be appropriate in this case because the patient did have PEM. So rather than using something like this, it'd be more appropriate to screen for post-exertional malaise and prescribe activity pacing instead. 1 year later, she was referred to a PT specializing in POTS with the instructions, the key treatment for POTS is exercise. This is the only research validated way to recondition your heart. But as I mentioned before, a lot of the research shows that it's not an issue at a central limit. It's not an issue with the heart. And she had her testing of her heart and lungs, and they were fine. They respond normally. It's an issue at the level of the cell being able to utilize oxygen and utilize the aerobic energy system. So there's not a need to recondition the heart when the issue is a peripheral issue and there's already damage or dysfunction of the aerobic energy system. So she was advised to do the CHOP protocol. She was also referred by neurology and with the advice begin with graded therapeutic exercise. So in this case with this patient, it would be more appropriate to put in the referral saying screen for post-exertional malaise, prescribe activity pacing, energy conservation, and ADL management, since aerobic exercise, it's not working for this patient. And I'll show you why. So the patient was seen by a physical therapist specializing in POTS for 3 visits. And the therapist noted exercise attempted but not gone well, and ADLs are limited. And then the therapist ended up doing several exertion-based tests, like the 6-minute walk test, 30-second sit to stand, and encouraged set a goal to progress the heart rate by 5 beats per minute or the effort level, and then prescribed activity pacing, heart rate pacing, education on PEM. So those were good things to provide to the patient, but then provided an early version of the Utah ADAPT exercise protocol with the instructions to do cardio programming in reclined positions for 20 minutes, or starting with 5 minutes, but building to 20 minutes and trying to raise the effort level. And that doesn't work in these patients who have post-exertional malaise if exertion and the aerobic energy system isn't functioning. So in this case, it would be better to minimize the exertion-based examination so that the patient, to reduce the likelihood of PEM, and to focus on activity pacing instead. So then she was referred to me 4 months later, and I asked her how therapy was going. And she said she was encouraged to do recumbent leg cycling, keeping her heart rate below 105, and to build the duration over time. But she didn't feel like the exercises were helping. They were making things worse. And so what we did instead, those are some of her symptoms. I screened her for post-exertional malaise or symptom exacerbation. And as you can see from this screening tool created by Workwell Foundation, one of the key features is, does it take more than 1 day to recover back to your baseline after activity? As I mentioned during the cardiopulmonary exercise testing research, that taking longer than 24 hours to recover is a sign of post-exertional malaise, or can indicate that that patient might have PEM. And then, does exercise or activity positively affect you? And she said no. So it takes her several days to recover after any type of exertion. So she had high PEM severity and irritability. And she wasn't really doing well with the therapy from before. So, and she hadn't noticed improvement or any improvement in her symptoms with exercise. I also screened her for mast cell reactivity issues, and these are some of the symptoms she described. I also used the Bateman Horne Center Good Day, Bad Day questionnaire to assess her good days versus bad days and how much upright activity she could tolerate. And then here's some of that information. So I didn't do a NASA lean or an active stand test because she had already undergone tilt table testing, and I wanted to minimize the amount of exertion from the exam. And here are some of her, using the patient-specific functional scale to assess some of her activities, what she scored. So here are her impairments and functional limitations. As you can see, she has a higher level of symptom burden. So the first goal would be, oh, that didn't show up right, but first goal is to reduce PEM episodes. So we want to provide education on post-exertional malaise and set expectations for rehab. And so I taught her about post-exertional malaise, advised her to discontinue the exercise program, and then we focused on activity pacing, heart rate pacing, and really getting that fine-tuned, as well as pacing her upright activity, and that was more effective. So pacing is a huge part of our life. We spend 95% of our day just living and doing our ADLs, and only a small portion of our life doing exercise. And for these patients, they're already exceeding that threshold. So activity throughout the day is already putting them at high levels of exercise just doing their ADLs. So they don't need more exercise. That actually causes a worsening of their symptoms. So here's a handout full of ideas for energy conservation for your reference. I taught her to recognize the immediate symptoms of overdoing so that she would prevent those delayed symptoms of overdoing. And then we worked on activity pacing. When she feels symptoms or an activity starts to feel difficult, or she becomes short of breath, she needs to stop. Don't push through the symptoms, elevate her legs, lower her heart rate, all these ideas. And then we talked through heart rate pacing to act as a way to alert her when she was overdoing. And here you can use these for your reference as well. And then we talked about pacing her upright activity for the orthostatic intolerance. So whenever she feels symptoms, she needs to take a break, lie down, elevate her legs frequently throughout the day. And then we addressed mast cell activation and diet, and I referred her to an allergist and dietitian for those. And then as she got those addressed, she had less GI symptoms and started experiencing more good days. And why would a rehab provider need to know about mast cell symptoms? Because exercise can, or other interventions can trigger mast cell degranulation, and symptoms of mast cell degranulation can interfere with a patient's tolerance for therapy. And it's pretty prevalent in long COVID. So here's all the ways that mast cell symptoms can affect therapy tolerance. So therapists need to be aware that this is a factor limiting somebody's tolerance for therapy and needs to be addressed. So we did 5 virtual visits over 4 months. She discontinued exercises based on my recommendation, and she started experiencing more good days than bad days, fewer PEM episodes. Her heart rate variability increased, and she rated her overall function as higher. So she noticed that that was a much more effective for her, and she has to manage this long term. So you can see her function improved in some areas, but you can see that the aerobic function of walking more than 30 minutes didn't improve as much as short bouts of activity, since that aerobic energy system isn't functioning the same way as it used to. So PEM is not due to deconditioning or laziness or psychological issues. It's an issue of energy production at a cellular level. So last case I'll go through quickly. A female in her 40s became sick with COVID and diagnosed with POTS, and she started with me and PT 15 months later. She had already been trying to do exercise laying down. She was doing a rowing machine daily for 30 minutes and doing recumbent strengthening and all these things, but she said it didn't feel like she was seeing progress. So she was already working on a lot of this, but she was trying to push herself more because she was thinking that would help her recover faster. So I spoke to her about this post-exertional malaise. This is a screening, some of the questions that I use to determine whether a patient, kind of to lead me to whether or not to try exercise. It's not perfect, but it helps me. A lot of patients notice that if they have post-exertional malaise and I ask them, do you still have symptoms when laying down, like with cognitive effort or social effort or sensory, then that's a sign that they're at a much lower level of function. And so even laying down doing cognitive or sensory or social activities can trigger PEM. So this has been helpful for me. I don't know if it'll help others. So she was getting 2 to 3 day crashes from being upright for long periods of time, and exercise didn't seem to be helping. She was already trying that. She said, though, if I could live my life lying down, I would be able to function normally. As you can see, she was functioning at a higher level than the previous patient. And so here's some other things. I want to leave time for Amy. But you can see she was already rowing 30 minutes, doing deadlifts, working out. And so she had low severity. She was at a higher function. So she likely had a higher anaerobic threshold. So we did still talk about PEM, but we set heart rate alerts to prevent her from going into that anaerobic threshold. And she figured out that it was around 130, that if she crossed that, then she would have a crash the next day. And so as she worked on pacing, upright activity, she actually saw huge improvement. And so we did 2 appointments over 6 weeks. And this is, I think I mentioned, about 15 months after getting COVID, but just doing the one visit, her function improved from 70% to 95%. And she started having more good days and decreased PEM episodes per month. So that's how she rated her function after one visit of therapy. So here's some principles to take home, and you can reference, but basically both patients I treated with activity pacing and pacing upright activity, and it was more impactful than exercise. And so staying below that anaerobic threshold can be helpful for these patients, and reducing the amount of aerobic activity or aerobic exercise or endurance activity. And as you can see, virtual visits can be effective. Virtual rehab can be effective. PTs need to do more than just exercise these patients. We need to be knowledgeable about other factors like mast cell, post-exertional malaise, and adjust our treatments accordingly. And I'll turn it over to Amy.
Thank you very much, Clayton. And let me try to share my screen. So, occupational therapy is a healthcare profession that assists individuals with managing their jobs of daily living, which represent the unique roles that define a person's life. When disease, injury, or illness disrupts an individual's life, their occupations, such as being a parent, a friend, an artist, a student, a pickleball player, a community member, may be altered. And occupational therapists work to help patients restore, rebuild, and redefine their quality of life by facilitating engagement in meaningful and purposeful activities. Occupational therapists use their extensive medical school level training and utilize frames of references to conduct assessments of patients' strengths, deficits, and their individual needs. These frames of references serve as a structured treatment plan aiming to assist individuals in improving their functional performance for daily living skills. Treatment plans encompass diverse dimensions, including physical, sensory, and cognitive considerations, all shaped by the patient's illness and personal life context. For patients, an individualized approach is necessary, emphasizing specific frames of reference given the uniqueness of each patient's symptoms. Most protocols, such as CHOP, are diagnosis specific, and they're frameworks that lack the sensitivity for PEM. For patients who have PEM, the framework or protocols need to identify PEM and emphasize the impact or consequences of activities on symptom exacerbation. I will delve deeper into this how-to later in my presentation. Conventional OT or PT guidelines, when not considering PEM, concentrate on the visible or quantitative and qualitative aspects of a patient's performance, such as measuring the strengths or endurance demonstrated in a clinic setting, resembling the tip of the iceberg. Most deficits are observable, allowing therapists to witness the impact or the injury or the condition on performance. The primary goal is to enhance activity and restore health function, ultimately achieving an improved quality of life. While the physician's referral may emphasize incorporating graded exercise or activity, PEM remains hidden, occurring hours or days after the initial stressor and out of sight from the provider. Patients are often too unwell to maintain a therapy schedule, and leading therapists to assume that they have resumed their normal life or that they lack motivation to continue therapy. The hallmark criteria of PEM, is not attributable to deconditioning or false illness beliefs. Graded exercise promotes scheduled increase in aerobic activity, even if symptoms are exacerbated. The rationale behind increased symptoms is normalized as a typical response. Both graded exercise and cognitive behavioral therapy involve grading exercise as a means to enhance activity. Cognitive behavioral therapy aims to change the false illness belief or the cognitions and encourage increased activity or behaviors. These approaches overlook the extensive evidence of neurological, immunological, autonomic, and energy metabolism impairments. They propose that ME/CFS, fatigue, and disability stem from inactivity and deconditioning, as Clayton had said. But these are false assumptions and not only fail to enhance functioning, but also have detrimental effects on the health of this patient population. So what do? Pacing for PEM represents a paradigm shift, emphasizing patients' lived experiences, describing the consequences of activity on their occupational roles. This approach involves recognizing immediate and delayed symptoms, analyzing activities within PEM limitations, and integrating preemptive and recuperative rest to improve overall quality of life. A physician's referral for occupational therapy and/or physical therapy must include an evaluation for post-exertional malaise, address symptoms, and implement pacing strategies for enhanced daily functioning. Pacing is a method for effectively managing exertion over time. There are three distinct categories of pacing, and the first one being pacing for individuals without significant health concerns. This is everyday strategies for managing responsibilities of work, play, and leisure. Pacing for therapeutic strategies are tailored for those with an intact metabolism and without disease-causing PEM, but this approach involves a more intricate process, and with the guidance from medical providers, from therapists, individuals can self-assess and learn how to modify activity levels. But going down to a deeper level, pacing for PEM is geared towards impaired metabolic functioning. This specialized and crucial strategy involves managing tasks, exertion, and recovery over time. Pacing for PEM must consider exertion before, during, and after the task, becoming a lifestyle approach for symptom management. To screen for PEM, Clayton went into some of this detail, is to evaluate individuals by asking questions that assess the impact of exertion on their ability to tolerate it, distinguishing between those who experience PEM and those who do not. What happens when you engage in normal or previously tolerated activity? How much activity does it take for you to feel ill or trigger illness worsening? The nature of these questions ask, what are the consequences of exertion or activity? Here's an illustration of a functional scale depicting the range of severity and impairments in occupational performance for individuals with mild to severe ME. Each level on this scale highlights the profound and debilitating impact the disease has, underscoring the considerable impairments it possesses on patients' overall performance of daily living. These patients are describing their ME as mild, may engage in activities where their symptoms are not immediately evident. However, despite participating in events, they experience a crash, prompting a withdrawal from public view. Those in this category typically describe it as remaining mobile and self-sufficient, managing light domestic ADL tasks with some difficulty, and performing employment or school duties with modifications. Moderate ME is a reduction of mobility and may use mobility devices for energy conservation. It's a 50% reduction in pre-illness activity, and this is considered moderate. Unable to work or attend school full-time, and they are considered home tethered. They don't get too far away from their home without needing to go back for their recuperation. And severe ME, able to carry out minimal ADLs with moderate amount of assistance. They require daily caregiver assistance. These individuals are homebound and bed tethered. And very severe ME, unable to mobilize or carry out any ADLs for themselves, need assistance with basic functioning and position care, and they are bedridden and limited bed mobility. The upcoming slides, I'm going to showcase two patient cases. The first one is patient number 1, a 40-year-old female residing in a second-floor apartment with her husband and dog. And she enjoyed relatively good health before her COVID infection in 2022. With occasional migraines, she worked full-time without needing modifications to her active lifestyle. Her current diagnosis includes COVID-related ME, POTS, EDS or Ehlers-Danlos syndrome, mast cell activation, and migraines. Her primary symptoms involve fatigue and cognitive decline, worsening beyond baseline function and persistent for days after activity. In terms of ADLs, she performs baseline activities with mild assistance for setup and management of materials. When she surpasses her baseline, her ADL crash performance level requires moderate assistance for basic care activities. Her IADLs, her instrumental activities of daily living, at baseline, she needs moderate support for single-step activities like putting dishes away, or folding laundry. But during a crash, her IADL levels render her unable to perform any of those activities. There is a distinction between her immediate and her delayed onset of PEM, with her delayed symptoms appearing 24 to 36 hours post-stressors. And patient number 2 is an 18-year-old male who lives with his parents in a single-family home. His bedroom is on the 3rd floor. He was relatively healthy growing up. His mother reported he may have been hypermobile, but that actually helped him as a swimmer. He was a full-time high school student, and he was an athlete prior to an unknown illness in 2021, for which he has not returned to baseline. He is now diagnosed with ME, POTS, Ehlers-Danlos, and also mast cell activation. His primary symptoms of fatigue, poor processing, or cognitive fog. He has abdominal pain, and he has fluctuating and disrupted sleep cycles that are exacerbated with activity and stressors. In terms of his ADLs, he performs baseline activities with moderate assistance for self-care activities such as brushing his teeth or eating at bedside. When he surpasses his baseline, he is unable to perform his ADLs without maximum assist and goes without activities beyond his primary care. It goes down to basic feeding and toileting or bowel and bladder regimen. For IADLs at baseline, he is unable to perform IADLs even at his baseline. There is a distinct difference between his immediate and delayed onset symptoms. His delayed symptoms appear 2 to 12 hours post-stressors. So it is crucial to take inventory of a patient's symptoms and provide order and structure to what may initially appear as random presentation. This structured approach helps both patients and also their care team better understand what the effects of medicine and therapeutic strategies are on symptoms. And patients with better understanding of their symptoms can differentiate between those that are merely annoying or disruptive and those that are more severe and significantly impact their daily functioning. And I'd like to acknowledge the Workwell Foundation for providing this framework, that the symptom time course is an instrument in identifying patterns of symptoms, differentiating between immediate and delayed onset. Immediate symptoms are those stop signs for announcing that when an individual has done too much and they need to start ending the event that they are participating in. And then the delayed symptom is the crash. How long does it take until I feel the impact or the consequences of this stressor? And what are those specific symptoms and when do they appear? As patients become more aware of their immediate symptoms or their stop signs, they can also discern how certain stressors can exacerbate these symptoms. By distinguishing between physical, cognitive, and social emotional stressors, this helps unveil distinct symptom stop signs. With an enhanced awareness of these responses, patients can now make more informed choices, enabling them to do more planning and integrate meaningful activity into their present and future schedules. This aligns with the core concepts of pacing. So for patient number 1, her immediate stop signs for PEM are for physical cues are increasing heart rate. And she notices when it goes to 110 beats per minute, she needs to start slowing down. She gets dizzy and lightheaded, and she has foggy thoughts. Cognitively, her stop signs include, she says her head starts buzzing. She has difficulty with finding words and expressing her thoughts. And she also describes getting a coat hanger pain across her shoulders and neck. For social emotional stressors, she feels more of pressure in her ears and ringing in her ears. She gets a headache quicker, and she also finds it very hard to follow conversation. So task analysis is taking the inventory of the tasks, what needs to be done, and prioritizing. Where is it on my to-do list? And then analyzing these tasks is, what must I do? What is the top priority? What might I do? And what do I wish I could do? Or what may I do? This involves evaluating the importance of this task, the stressors and the symptoms, and how meaningful it is to one's occupation. Activity analysis involves breaking down the tasks like grooming into specific activities like brushing your teeth or washing your face or combing your hair, and assessing these conditions for what achieves that goal. This includes planning and pacing. Planning is defining the criteria for each of these activities. Is it using mouthwash, or do I need to use a toothbrush, a sink, and possibly even floss my teeth? What constitutes the activity for toothbrushing or keeping oral hygiene? Pacing is completing activity based on your energy and your symptoms. There are no strict rules and there are no timelines. So modifications and adaptations are providing the changes to the environment or activity for the desired outcome, which are the adaptations, and adjusting the outcome to meet the individual's needs, modifications. So examples include simplifying face washing, simplifying the steps, or limiting the use of multiple steps of grooming, such as keeping a hairstyle simpler, not doing multiple steps for doing one's hair or one's makeup, keeping tasks as simple as possible, cutting out different unnecessary routines just to meet the goal of the task. And after identifying prioritized and meaningful activity, I collaborate with my clients to plan and pace their activities. In this next slide, I will go deeper into this process using the example of patient 1, but with these concepts in mind. So patient number 1, we prioritize the grooming task of getting ready for the day. We processed how to break it down into specific components of this activity and examined how various stressors might be exacerbating her symptoms. For bathing, we analyzed the time of the stressor, considering whether it could be done with less frequently, maybe 3 times a week or 4 times a week, and at different times of the day. Can it be done in the evening? Does it have to be done in the morning? Or for shorter periods, can it be done in 2-minute or 3-minute wash? We explored options such as using bath chairs, or whether it could be done in a tub, bedside, or even just with a washcloth for added support. We addressed cognitive stressors. We evaluated the possibility of simplifying the activity with fewer steps and incorporating picture charts or cue cards. For sensory, the considerations involved adjusting the lights, maybe unscrewing some light bulbs or using light dimmers, turning the noisy fan off so she doesn't have to listen to the fan in the bathroom, using softer water spray settings on her shower head, opting for less intense smelling shampoos or soaps, and using softer towels, or even just going right into the robe without even drying off on a towel. And for emotional, we looked at addressing maybe using soothing music or sounds that can help her with calming her body so she's not feeling so many emotional or different stressors that relate to emotion. Environmental factors to consider can be the timing and weather conditions. Is the barometric pressure changing? Is it dropping? Or what types of weather conditions really affect her symptoms? Are there a lot of high count molds in the air that she needs to accommodate for? So while it may seem detailed to go to this level of analysis, this is actually really crucial in helping to identify the triggers and help this individual perform these meaningful tasks to her daily function. And then for those about rest, this is a big component of pacing, is for those individuals that do not experience PEM, there are typically 2 types of rest, and the first being recharging rest for relaxation, and the other is convalescence rest for recovery after an illness or an injury. But for individuals with PEM, radical rest is an aggressive, energy-saving conservation management of rest. And it involves preemptive rest to stabilize baseline function and recuperative rest to return to baseline or avoiding causing future harm or additional harm to the body. This slide illustrates patient number 1, the symptom time course through an activity and rest analysis. Here she prioritized cognitive, physical, and social emotional activities and selected an in-home date with her husband. We identified immediate stop signs and delayed PEM symptoms for social emotional activities. And by reviewing the days before and after these events, we emphasize the importance of accounting for delayed symptoms, providing her with control over these symptoms for schedule planning purposes. So this is an example of how I would go deeper into analyzing the domains of activity in an occupational therapy perspective. And I just wanted to put it out there so you can look at it in deeper analysis just to see what an example might look like. And then this example is a functional capacity scale that is looking at the consequences of activity. So there are different types of functional scales, and I just wanted to offer this as one option for really capturing consequences of activity. And I am finished. Thank you very much.
Amy and Clayton, thank you so much. I think that each of you have really shown through your presentations just how vital and important it is, not only that there is a consideration around PEM and just about everything that we do, right, and screening for that, but also just how influential both PT and OT can be for patients, especially those with post-exertional malaise. What questions do you have for our speakers today? I'm going to share the other FunCap questionnaire that Amy just showed on the screen. Dr. Brown?
Yeah, great discussion by both of you. I think, this is kind of maybe for the mild to moderate patients that experience this, but, this is generally a patient population that are youngish, active, pretty full lives before this sort of hits them and sidelines them. And things like exercise and other activities that they were doing prior really serve a function in their life for emotional coping or some of those other things. And so while I think it's sometimes easy for us to say, well, stop doing those things, it's hard because I think we have to sometimes focus on what do you replace them with, or how do you meet those needs? Do either of you two have things that you suggest to patients when they're sort of struggling emotionally because they've lost some of their coping mechanisms?
So one of the examples I can use is one of my patients loves rock climbing. That was huge for her. And so she would actually, it's like we would prioritize rock climbing. She had to save energy from doing other activities in order so that she could go rock climbing. But then as I explained to her the limits of those energy systems, she would rock climb for a minute or two, and then if she started getting symptoms, she'd stop and take a rest break and lay down and get those symptoms under control. And then she was able to manage it so that she could do some of the activities she wanted in short spurts if she prioritized saving her energy up enough to be able to do something like that. Now, in terms of aerobic exercise, that's really hard because it's an aerobic energy system dysfunction as well. So oftentimes we have to find an alternative activity that's a little bit more and not as based on endurance. And so that is a challenge in that patients eventually do often find it's like, it used to provide me a lot of these benefits, but now I have to find alternative ways to get those mental health benefits without pushing into post-exertional malaise.
And I want to add in that Clayton sees patients in clinic setting typically or virtually. I see patients that are mainly homebound, and these patients are trying to reestablish their occupations of just being a family member, just being part of a community. So I really try to emphasize how to bring the core of their role. What is it that they want to reestablish in their life? What have they lost that is so core to them? And try to take away the other work, take away the having to think about some of the more complicated, the ADLs, things that they don't necessarily need to do at that moment, but bringing their visit with the grandchild, or being able to celebrate and have dessert, have birthday cake for somebody's birthday, figuring out how to make the core, the essence of that emotional event, be the most meaningful to them. So sometimes it's missing out on a lot of family meals or all family meals, but bringing in the birthday cake so that they can eat with the family member that needs to celebrate and be part of them. So trying to kind of declutter the rest of their life so that they can figure out what the core of their essence is how I try to help people kind of regain that identity.
Thank you, Amy. Dr. Yeoman?
Clayton, this question is for you. I've seen you see a few of my patients and use pneumatic compression devices or boots to sort of assist in recovery after mild physical therapy exertion when patients have PEM. Do you mind touching on that and how that's sort of moved the needle a little for these patients?
Yeah, no problem. Working with a lot of patients, they would report to me that pneumatic compression was more impactful for them than wearing compression. So they noticed that, like, if I go to the grocery store, I'm exhausted and I feel fatigued. Which I would tell them to get the groceries delivered or have some other method. But if somebody goes in there, they notice they can bring the pneumatic compression with them. It's battery operated. They can put those on, and then it helps push some of that blood back to the head. And then they'll report like they can then drive home, or they use it as a tool to help with some of the orthostatic intolerance. And we in the clinic, we have one that circulates cold water through it plus compression, and it can help with some of the orthostatic symptoms. That's reduced cerebral perfusion. So that's a tool that a lot of patients have found useful throughout the day to just help them recover faster. I use the analogy that it's kind of like your old chargers with your phone. You would charge with, it would be slow charging, that this is a little bit faster charging, that you can charge your battery up a little quicker and recover a little faster.
Thank you. I want to ask one more question, and I know that one of our mentors has to hop onto another echo. When you work with the referring provider to you, you mentioned in a couple of different ways some of the different referrals that you receive, and then how you end up, kind of recalibrating as a result of seeing the patient and assessing that they do indeed have PEM. How do you work then with that referring provider to help them either adjust or modify the way that they're approaching the care?
Most of my patients already come from physicians that understand post-exertional malaise. So I am not seeing patients come from, I guess, the general medical community. I'm seeing specialized care providers that I can work with as team members. So I think that just being able to document and really reinforce the idea that these patients have different types of symptoms, and helping the healthcare team overall manage the symptomology of each patient, and say, like, this, by us managing these symptoms, this medication can be used more effectively, and giving kind of feedback to the providers that way. Clayton?
I think results speak. If you get results and patients are reporting increased function and lower symptoms, and they're feeling better, they have a higher quality of life, then you can show that this works, and don't need to necessarily, or sharing research articles. So research articles explaining some of the symptoms of post-exertional malaise and things, and that exertion hasn't been shown, or graded exercise hasn't been shown to be helpful for these patients.
Wonderful. That brings us to our hour. Thank you all for your time today. We will pick up in January. We have a great lineup for next year as well, so we hope to see you then. Sarah and I will get some marketing out around that so you know what's coming. But thank you to our mentors. Thank you to our two speakers. This was great. Everybody have a happy holiday.